Look at this room. We have a lot of people in here. This is really awesome. I think we've got far more people than we had last year. I hope that comes back once you touch it. So I just want to introduce our first speaker this morning. This is Dr. Min Park. He is the Director of Cerebrovascular and Endovascular Neurosurgery at the University of Virginia. And we have a CCM clinical center at the University of Virginia, so we have comprehensive multidisciplinary care there. And Dr. Park is the director now of that center as of sometime this year. And some of you may have caught him with his webinar on vitamin D in relation to our illness earlier. If you haven't, it's on our YouTube channel. Please be sure to watch it because it's really important, but I think he'll probably repeat some of this here today too. So please give a round of applause for Dr. Park.
I'll be talking about cavernous malformations, or cavernous angiomas, and clinical decision-making as it pertains to neurosurgery, as well as a little bit of information on vitamin D. As Connie said, if you watched the webinar that I was able to participate in, we did go over some of this information. So I have no disclosures, and for those of you who are into college athletics, it was a really good year to be a WHO. This is the UVA lacrosse coach in the national championship trophy, so it's always our second national championship last year. So we'll be going over introduction just about what cavernous angiomas are, talk about the natural history because that's very important in how we determine the best care for patients, as well as the genetic studies. We saw some of that this morning. That's an area of a huge amount of research for cavernous malformations, as well as talk about what we do in terms of management options when we talk with families, when we talk with patients, and try and determine what the best care going forward with is, as well as a little bit about vitamin D. So cavernous angiomas has many names. They are called cavernous malformations, cavernous angiomas, cavernomas, or CCM, which is cerebral cavernous malformations. And all of that is referring to basically the same thing. They're well-circumscribed vascular lesions. They have no intervening normal brain in between them. And they're sinusoidal channels, and they have blood of different ages. They have blood that's in a liquid phase, as well as thrombus, which is basically blood that's clotted off. The prevalence is up to about 0.5% per of the population walks around with us, and it really depends on what type of study they use to determine how many patients could be affected with it. The genetic component, those with the familiar hereditary version, definitely cluster. New Mexico has one of the largest populations just because of the prevalence of the genetic mutations there. And again, they're basically two types. Those that are just sporadic in patients who have no family history, as well as those that are hereditary. And with that, the inheritance pattern is what's called autosomal dominant. So that means 50% chance that someone who has the gene mutation will pass that on to their children. And it's regardless of the gender of the parent or the gender of the child. More commonly, they present with seizures, new onset seizures. About 60% of the patients, when they present to the emergency department, will have this, will be because a patient who's never had a seizure before has one. It's obviously very concerning. They come to the hospital and they'll get a workup for that. Hemorrhages are a little less common, and that's when the cavernous malformation will cause a bleed, a symptomatic bleed, something that someone notices and says, hey, this is different. And headaches are the most common symptom when someone has a bleed. It's just a headache that's outside of the ordinary. And even patients I've had with migraines and debilitating migraines where they might not be able to go work for several days, have to lock themselves in a dark room. Whenever they have a lesion like this that bleeds, even they know it's different and say, this is very different than my usual headaches, or patients who've never had a headache before and all of a sudden have a very severe one, and that drives them to go to the emergency department. They can also present with neurological deficits, almost like a stroke symptom, without a significant bleed or any other event, and that obviously is concerning, and patients will come and get evaluated for that. More and more, we're seeing them as incidental findings because imaging studies are becoming more prevalent, and they're just easier to find and easier to get. So an MRI scan for someone who has a routine headache as part of their evaluation may find a cavernous malformation, or in trauma. Someone has a traumatic event, we come to the hospital for evaluation, and again, we'll get some scans, and that might lead us to a diagnosis of an incidental cavernous malformation. Seizures, these we believe are caused because cavernous malformations will have small repetitive bleeds. And a lot of times they're not significant enough to drive someone to the hospital, or they're completely asymptomatic. But when we look at the imaging studies, when we look on the MRI scans, we'll see that there's what we call a hemosiderin ring, or basically a pattern of blood that's old blood and scar tissue around the cavernous malformation. We believe that that hemosiderin ring basically is the focus for seizures. It leads to gliosis, which is just a fancy term for scarring in the brain, and inflammation. So patients who present with hemorrhage with a cavernous malformation are more likely to develop seizures than someone who's found incidentally, like following a car accident or some other reason for getting scans. And the rate of new onset seizures for patients with cavernous malformations is a little under 2.5% per year. That being said, those who do have initial seizure with cavernous malformations have a higher risk of developing what's called epilepsy, and that's just repetitive seizures. So a seizure is the one time that happens, or that one event. Epilepsy is a condition where you have that repetitively, and just over time that the seizures are not being controlled, and you can develop epilepsy. Hemorrhage is what we're all scared of, because these hemorrhages can be, depending on their location, they can be very significant and cause a lot of problems. When we look back at the historical literature, and that's where we find patients and kind of figure out, based on the patients that you've identified, what is the hemorrhage risk. We think it's about 2% per year. As we've learned more and more about the natural history, we can actually divide that up and be a little bit more precise as to what we think the hemorrhage rate is, depending on the type of cavernous malformation you have. If it's found incidentally, the hemorrhage rates are usually pretty low, less than 1% per year. Those who present with a hemorrhage actually have a higher risk of bleeding, and that just likely because of the biology of that cavernous malformation is more dangerous. They've presented with one hemorrhage, they're just prone to develop more hemorrhages. With seizures, it's actually pretty low, but cavernous malformations in deeper structures like the brainstem or spinal cord may have a very significant rate of future hemorrhage, and those with extralesional hemorrhages, that's where we say the hemorrhage is larger than the cavernous malformation itself, those patients probably have the highest rate of subsequent hemorrhages. And we actually looked at the hemorrhage risk of untreated isolated cerebral cavernous malformations, at least at the University of Virginia. And this is a patient cohort that we looked at retrospectively. It's an isolated cerebral cavernous malformation. So these were patients who did not have the familial form and also did not have multiple cavernous malformations. And the previous hemorrhage, having a previous hemorrhage was the highest indicator, the most likely patients who would develop subsequent hemorrhages in our patient population. On initial workup, if you present through the emergency department, the CT scan is probably the first imaging test that they're going to get. The problem with CT scans are they're not very good at detecting cavernous malformations. If the cavernous malformation bled, we might be able to see that. If it's been there for a while and it's developed calcifications along it, that's something that the CT scan can see. But overall, this is not our imaging test of choice when we're working up a patient. The MRI scans have the best sensitivity and specificity. That means they can detect them, and then we can accurately predict that it's a cavernous malformation. So this is our test of choice. And especially depending on the sequences you use, they can be very, very sensitive, especially like the SWE images and GREs, gradient echoes, that really look at blood within the brain parenchyma. Angiography, these were historically called angiographically occult vascular malformations, which basically means we know that cavernous malformations are formed of blood vessels, but when we do an angiogram, which is an invasive procedure, but it's a fairly safe invasive procedure where we take catheters and go directly into the blood vessels and inject contrast directly into the vessels, you won't see the cavernous malformation. You could see what's called a developmental venous anomaly, and that's there in those pictures on the lower right. That's actually just a normal variation of venous drainage. Prior to my time, when we used angiography pretty much exclusively for diagnosing lesions, this is pre-CT era and pre-MRI era, when you would see this, you would say, this is abnormal. We need to do surgery on this, not fully understanding the implications. That's a normal vein, just with an abnormal appearance. Those ended up being pretty devastating cases because now you're really disrupting the normal blood flow pattern to the brain. So whenever we see a developmental venous anomaly or a DVA, we have to be very careful when we're planning for surgery because you do not want to disrupt that structure. As we know, the biology, there's three mutations that have been, three genes that have been implicated with cavernous malformation formation, the CCM1, CCM2, and CCM3. And these are genes that encode proteins that help with basically the endothelial cells, or the cells that line the blood vessels, how they interact with each other and how they basically attach to each other. And a disruption of any of these three leads to leakage around those blood vessels, and that precipitates cavernous malformation formation. CCM1 is the most common variant. CCM3 tends to be the most aggressive. In sporadic cases, which are the vast majority of patients with cavernous malformations, is usually a single lesion. You find one. As we're learning more, historically, we thought this was not related to a genetic mutation, but we're learning more and more evidence that, in fact, it could be. And oftentimes these are associated with the DVAs. Familial presentation, about 20% of the patient population will have the genetic mutation. And as we talked about with autosomal dominant, that means, again, you have a 50% chance of passing that characteristic, that mutation, on to your offspring. Variable penetrance means it can be of different severities. Even though you may have it, it may not be as severe, or it may be less severe than your parent or your child would have. So it's not consistent as to how what the number of lesions you have, where they are, how severe the disease manifests. And oftentimes, these are the patients that have lots of cavernous malformations. So on these sequences here on the MRI scan, all those polka dots, those are all different cavernous malformations that a patient has. When we see patients in our clinic, definitely if there's a family history or if there's a multiplicity of lesions, we would always recommend that they undergo genetic testing. And for that, we sequence all three of the CCM genes with our geneticists. And again, about 75, maybe 80% of the patients with a familial form, we can identify the specific mutation. Even if we're not able to identify the specific mutation, does not mean you don't have a familial form. It just means there's something that we don't quite understand in this present day. And with time, we'll be able to figure that out as well. And as we said, CCM1 is the most common gene mutation. For patients, when we're talking about, okay, we have a diagnosis, we have a full understanding of how many lesions you might have, where they are, if you have the genetic variation or not, and then we say, what do we do? And like everything that we recommend, we have multiple choices. One is conservative or medical management, two is surgical resection, and there's some evidence as to whether or not radiosurgery like gamma knife may or may not be beneficial. So if a patient presents and this is an incidental finding, and again, it's not that uncommon that we'll get a call from my residents in the hospital saying we have a patient with a motor vehicle accident and they're doing a workup, or I'll get a call from either a neurologist or a primary care doctor saying, hey, I just sent a patient who had chronic headaches for a scan. This is what we found, and we'll go talk with them. We do a very detailed, careful history, see if they've had anything like seizures, any neurological deficits, any severe headaches in the past, to figure out if this cav mal has had any symptoms. If it is asymptomatic, we can generally leave it alone. We don't have to do anything about it. We can just say, well, we'll just keep it. Usually we follow it for several years with serial MRI scans. Or if something happens, if all of a sudden you have a worst headache of your life type of situation, or you have a seizure, then we'll scan again, and then we have to readdress what our initial plan was. There are novel therapies that are under investigation, and we'll talk about vitamin D in a little bit, but we've already heard about the statins and propranolol, and these are all studies that are ongoing currently, and they're identifying more medications that might be of benefit and might have some type of effect on patients with cavernous malformations. So this is just a listing of some of the recent publications, and several of these researchers are actually in attendance. Dr. Awad's group has been very prolific, and as he's one of the leading researchers in cavernous malformations in the country and in the world, as well as Dr. Whitehead, who's at the University of Utah. So who do we pick for surgeries? Those who are symptomatic, who've had a recent hemorrhage, who've had seizures or neurological deficits, are definitely someone we would consider for surgery. Just because you've had that doesn't mean that we're going to operate, though, because along with it, we had to see how dangerous is the surgery going to be. And that really is related to where the cavernous malformation is, because in certain areas of the brain, it's a very straightforward access, very low risk, and it can be something that we can do and tell patients with a high degree of confidence that we can take care of this and the safety profile is excellent. In other areas of the brain, we have to be much more guarded, because there are instances where the surgeon is much worse than the disease. And as a surgeon, whenever I'm advocating to do surgery, I always ask myself, what's worse for you? Am I worse for you, or is leaving it alone worse for you? And you have to have a very, very good idea as to where this lesion is, and understand the anatomy and understand the role of those functions of the brain before we would ever consider that. And lesions in the brainstem and the spinal cord, or in eloquent areas of the brain, which are intimately involved with maybe your speech centers or your motor centers, we have to be very hesitant before we would recommend surgery, and for only specific criteria. So why operate? And again, like we talked about, the risk of surgery has to be less than the risk of the natural history. And in this instance, a lot of times we're concerned about the hemorrhage risk, because the patient presented with a hemorrhage, that's a clear-cut indication to consider surgery as an option. And if the overall risk of what we think about of causing a problem, actually something that is potentially fatal to the patient or a severe neurological deficit, overall maybe about 6% risk, combined risk. We have to consider what is the risk then of leaving it alone. So the hemorrhage risk of an incidental cavernous malformation, one that was just found for nothing specific to the cavernous malformations, no history of bleeding, no history of seizures, we think the hemorrhage risk is about 2.5% over 5 years. So then you say, well, that's, surgery looks to be a little bit worse. So maybe we don't consider surgery at that point. This is an incidental finding. And I'm not going to beat, at least over the intermediate term, the natural history. If they present with a hemorrhage, though, then we know that the risk of the subsequent hemorrhages is significantly higher, in which case then the risk of surgery is actually much smaller than the risk of doing nothing. And then we would say this is something that we could consider surgery for. The risk of surgery is highly dependent on the location, as we discussed. The brainstem, where you can find cavernous malformations, there's not a square millimeter of that area that is not having some type of function. And so in those instances, if the cavernous malformation is right in the middle of the brainstem, is just surrounded by normal brain, it's absolutely not safe to do surgery, because I will cause much more devastating problems trying to get something out than if we just leave it alone. And generally what we wait for is for the cavernous malformation to eventually become a surgical candidate. And that requires that the patient have subsequent hemorrhages. As it hemorrhages, it might come closer to the surface, and it may take several hemorrhages. But what we know is those hemorrhages are still less dangerous than the surgery to get to something that's deep. And it doesn't sound comforting to say, you know what, we're going to have to wait until this becomes a problem, and it might have to wait a couple events, 2, 3, 4 events, before we feel that we could do surgery safely. Because it may take 10 years or however long to get to that point, but if we do surgery in an inappropriate time and we're actually going through normal brain tissue, what took you 10 years to get to a level of disability, I can do instantly for you. So that would deprive somebody of 10, 15 years potentially of a very good functional life, whereas I would potentially be robbing somebody of that. So again, for brainstem and spinal cord is the exact same type of situation. We really want to make sure that the surgery is less risky than leaving it alone. With patients with seizures, presenting with seizures, there's a phenomenon called kindling, where after you have the first seizure, you may become more prone to more seizures in the development of epilepsy, which is just a chronic seizure condition. And for patients with cavernous malformations, this is a definite risk. And so oftentimes if a patient has a new onset seizure, surgically accessible, what we do know is surgery does an excellent job of reducing the risk of future seizures. And in that instance, then it's something that we would advocate for surgical treatment versus just conservative management. They may be well controlled on anti-epileptic drugs, on anti-seizure drugs, but then surgery, if it is something that we can do safely with a low risk, might be better off in the long term. The hemosiderin ring, and this is a nice illustration of that, just basically the black ring around the cavernous malformation. It's important to remove all of that, or as much of that as is safe, to affect the best seizure control. And the longer you have seizures with cavernous malformations, our results in terms of making you seizure-free in the future are much worse. So just in terms of looking at what our risk is, if it's non-eloquent and supratentorial, which means in the top part of the brain, living with a CCM, the equivalent to surgery is living with a CCM for 1 or 2 years. So if it's a surgically accessible area and it's a candidate for surgery, after about 2 years, the benefit of surgery far outweighs the natural history. If it's in an eloquent area, because of the risk that we have, the risk that we pose to causing a problem, it's equivalent to living with a CCM for 5 to 10 years. So it does take time before that advantage of surgery in certain instances is really gained. And again, brainstem and spinal cord CCMs are a completely different animal. For surgical principles, we use something called neuronavigation. We've had it around for several decades now. It's very refined. What you do is you take an MRI scan and you can register it to a machine in the OR, and we can create basically a virtual map. And with a specific pointer that registers with the machine, we can put the probe, what we call, right on the skull, and it'll show you on the MRI scan where we are. I actually started my training before this came out. I'm a little older than, I got a lot of gray hairs, but I keep my hair short so you don't see it. But in the olden days, we would look at the MRI scan, make measurements with a ruler, and then come back to the patient on the table and measure things out. And you always have to make your surgeries bigger. You have to make the opening in the skull bigger because you're afraid of missing. The worst thing to do is do surgery and say, I don't know where this is. So to compensate for that, you just make everything a little bit bigger so that you have a higher confidence that you can find the lesion. Now we can localize to about less than 2 millimeters. So now all the surgeries are much smaller. When I started training, before my institution got this, again, we were doing those little rulers and measurements. Now incisions are much smaller, the opening in the skull is much smaller, and patients recover a whole lot faster. They underwent a lot less surgery. The surgery itself was a lot shorter, and it's been a tremendous boom to neurosurgery specifically. If it's up around the convexity, where we say kind of like the cap of the skull, it's fairly straightforward. You just make a little opening exactly over the lesion and do surgery to remove it. If it's at the skull base, which is kind of a deep seater or near the floor of the brain, there's all these different approaches that we use that have been well defined, and we have a whole specialty in neurosurgery called skull-based surgery to get to much more tricky areas. With surgery, this is all done under what we call Microsurgical Technique. We have a very fancy, very expensive operating microscope that's always used, and we're looking at things under high-power magnification. Here, it's basically the opening you're seeing might be, 2 centimeters, and whereas with the naked eye, it seems like a very tight corridor. When you're under the microscope, it'll seem like a freeway, and then you can just get there, just have a high index of it just gives you a much better confidence interval to see all the structures and preserve them. I routinely use neuromonitoring, which with the physiologist, the neurophysiologist. They'll put needle electrodes in the scalp and also in the arms and legs. And while you're asleep under anesthesia, it gives us a very good idea of how your brain is doing. Because the best way to check somebody is to talk with them and have them do tests. So every time you go in with the neurologists or neurosurgeons, they have you do the test, touch your nose, squeeze here, and things like that. We can't do that when you're asleep under anesthesia. So the neuromonitoring, the neurophysiologists help us out and just make sure that we're doing things with the highest degree of safety. We like to, if possible, take it all out as one piece. It just makes the surgery a little bit easier. There's a little less bleeding, but in certain areas we sometimes have to take it out bit by bit, and that's again for the brainstem and the deep-seated lesions where we have much less room to navigate and much less room to operate in. And like we talked about, for seizure control, we definitely are interested in removing the hemosiderin ring, the stained brain around, the stained scarred brain around the cavernous malformation. Again, for areas like the brainstem, that's not something we do. We just take care of the lesion. We're only interested in the hemorrhage risk there. And seizures don't generate from the brainstem anyway, so there's no need to be as aggressive in that area. And what we know in another study that we looked at in terms of what's the outcomes for brainstem cavernous malformations, they're not as bad as you would think. And you have to remember, these are carefully selected patients. This isn't all patients with brainstem cavernous malformation. These are the ones that met the very strict criteria for treatment. About 92% of this is looking at all the published literature out there. About 92% of the time, people were effective in removing the entirety of the cavernous malformation. In those small percentage that didn't have all of it removed, it actually has a pretty high rehemorrhage rate, almost 50% or just over 50% in terms of the rehemorrhage rate. Postoperative morbidity was significant though. Again, these are the most dangerous lesions. These are the ones that have bled maybe repeatedly and have already caused some sort of deficit in patients. And we see that up to a third of patients will have some type of deficit after the surgery. The good news is a lot of them will recover. Over half of them will recover to baseline or even better than baseline after the surgery. So that type of deficit you might have after surgery has a good chance of getting better and then make you better than you were before while eliminating the risk of you having a hemorrhage in the future. Radiosurgery is kind of newer. This is what's called gamma knife. It's used oftentimes in tumors or metastatic tumors to the brain. The literature is very mixed on it. Some people have been doing it for the most inaccessible lesions. Again, those are the ones deep in the brainstem, the ones that aren't safe to take out. And depending on the study, they seem to suggest that there might be a lower risk of hemorrhage in the short term from the lesion. That being said, radiation, even though there's not a knife involved, does cause damage to the surrounding areas. And the brainstem does not have an area that can tolerate any type of injury. So the radiation changes that affect the normal brain can be significant. People can have devastating consequences from that. So it has to be very carefully done. And obviously this is a potential area for research, but the jury is still definitely out on whether or not this is a good idea. We're far from advocating for this other than potentially as a treatment of last resort. We absolutely know we have nothing else to do. And so now transitioning to vitamin D. So vitamin D, just as a background, is a fat-soluble corticosteroid, which is a fancy term. A steroid is a chemical that's composed of 4 rings. Cico just means it's a broken ring. So one of the rings is broken. So you see the 3 rings there. The ring in the middle is an open ring of carbon. It has it's involved in many processes in the body. And inflammation seems to be one of the big things that we know about. We hear about vitamin D for bone growth and things like that. It helps with absorption of other nutrients like calcium, magnesium, and phosphate. There's 2 active forms in the human body, vitamin D2 and D3. Even though you can absorb it into the gut, the best way to get vitamin D is just being in the sun. Just going outside and getting a little bit of a sun exposure. we have a high prevalence of deficiency in certain populations. The elderly definitely have much higher incidence of what we call hypovitaminosis D, or low vitamin D levels. And in multiple studies, especially in the critical care populations, basically patients who have been admitted to an ICU for one reason or another, in the medical intensive care, they've studied this a lot, patients who might have heart problems or lung problems. It has been associated with much worse outcomes, with death and infections. And there are actually pretty good studies that say if we supplement vitamin D for certain patient populations, we can actually make them less sick and reduce their mortality in the hospital. I got interested in this actually for a different reason. We were looking at vitamin D as it related to something called brain aneurysms, and that's another disease pathology that I study and that I treat as a neurovascular surgeon. Just again, how research is, it's like going down a rabbit hole. You start to learn a little bit more, and all of a sudden another question pops up. And so we were looking at vitamin D as it related to aneurysms, and again, inflammation is very crucial in the part of formation of aneurysms. Started doing more research and saw that in the medical ICU, vitamin D actually had a very large role in, or had some function, and might be a very beneficial function in terms of addressing low vitamin D levels in patient outcomes. We just said, well, we have a large neuro ICU, why don't we look at that patient population? And we did multiple studies and had multiple papers looking at how vitamin D might affect our patient outcomes for patients with neurological diseases. It's not cavernous malformations in general, but any reason to be in a neurointensive care unit. Because of the recognition of inflammation and the potential role for vitamin D, there's been a lot of studies that have looked into this. This is the group from the University of Utah, Dr. Whitehead and Dr. Lee, and they came up with a very ingenious way of trying to figure out which chemicals or medicines might be beneficial for cavernous malformations. And basically what they did is they took drugs that were already available, because creating a new drug, getting it approved through patient safety, getting it approved through FDA is a years, potentially decades-long process with multi-million, tens of millions of dollars invested in it. But they said, well, we have all these drugs that are out there. Why don't we just screen them? And they had a nice model, and they were able to screen 2,100 drugs against their CCM model. And this is for CCM2 mutations. They found that vitamin D3 and Tempol were two medications that actually seemed to improve the disease in their model of mice. And again, this is absolutely genius. These are all drugs that are readily available. You don't have to get FDA approval to use it. Obviously, for a new indication, depending on the drug, you have to go through investigation, but this is just a great screening test. Dr. Awad, in collaboration with a lot of researchers, especially at the University of Utah, looked at just taking patient blood samples and seeing what do we find in patients who have cavernous malformations, who have aggressive form of the disease. And when they looked at this, they found what they call a chronically aggressive disease, patients who had cavernous malformation symptoms early in their lifespan, when they were kids or young adults, patients who've had multiple bleeds, and they considered those over time to be chronically aggressive. And those who had low vitamin D levels were found to have much more higher incidence of having what they consider chronic disease aggressiveness. So if you had vitamin D levels, for one reason or another, your cavernous malformations was acting up more than for other individuals. And this was statistically significant in this patient population. Additionally, when Dr. Lanzino at the Mayo Clinic, he looked at his patients and said, well, let's see what they're taking. Let's see which ones, let's take a look at our cavernous malformation patients. Let's look at what medications they're on, what their history. And then they found that the patients with seizures without hemorrhages, compared with incidental cavernous malformations, they were less likely to have chronic inflammatory disease or to have vitamin D supplementation. So these are all kind of inferences and associations. They're not at this stage giving us information as to how vitamin D might interact with it, but it's pointing to vitamin D as something to investigate. And obviously, there's a lot of investigations going on, and this is just one of a potential target that we can look at. The great thing about vitamin D is it's free. You know, you just step outside in daylight hours and you're going to get your medication. So this would potentially be one of the most cost-effective mechanisms, but there's still a lot of understanding that needs to happen before we could say that there is what role vitamin D has in the genesis of new cavernous malformations or the behavior of pre-existing ones. So in conclusion, management of cavernous malformations is really important, just like any disease in medicine, to have a very good grasp of what you're dealing with. You have to understand what the natural risk is, and even then it's what's the natural risk of this specific cavernous malformation versus that one. If you have a family history, how you present. As you can see, there's a lot of information that we have to process, and then figure out what is it in context with the risk of the treatment that you're proposing. There's a lot of novel therapies, as Dr. Awad referenced this morning, and I think that is something to be very optimistic about in the future. There's a lot of great labs, a lot of great minds hard at work trying to understand the disease process more and also figure out what's the best treatments for them. Perhaps they will make surgery obsolete, and that would be the ultimate dream and the ultimate goal for cavernous malformations. And vitamin D is crucial, and not just in inflammation, has some type of association with cavernous malformations. We're still trying to figure that out, but that might be something, as we talked about, is an incredibly cost-effective way to potentially treat certain patients. So I'd just like to acknowledge our team at UVA and also my good friend and colleague, Dr. Kalani. But thank you very much for your attention.
Take a couple of questions. I've worked with Amy to push our lunch back a few minutes, so Aaron.
Yes.
So there's a lot of research around vitamin D. What is the current understanding of supplementation versus just sun exposure? Like, is it worth supplementation?
The thing with supplementation is there's no downside, right? As long as you're not taking the whole bottle of Flintstone vitamins, if you take it with the recommendation, there's absolutely no downside to it. And we know it has so many other systemic effects. It's probably not a bad idea. Certain segments of our population are chronically deficient. So if it's not helping the vitamin, if it's not going to have a direct effect on the cavernous malformation, might just improve everything else too, though. So.
Supplementation of D3 is often like co-indicated with supplementation of K2, but because K is related to blood clotting and whatever, is there any significant correlation or contraindication there?
So if you're on certain medications, like Coumadin and what we call the anticoagulation medicines for clotting disorders, then definitely vitamin K is something that your doctor will say, hey, listen, you need to make sure. And they'll tell you, stay away from green leafy vegetables, stay away from carrots and things like that. Vitamin D does not seem to have an effect on that, so it should be independent of that.
I just have a quick question.
Mm-hmm.
Do you make a distinction? Let me back up. So my background is I was diagnosed back in '93,
Mm-hmm.
and then I had subsequent cranial MRIs. And as the cavernomas were identified, I had quite a few in white matter. And originally, way back when, they were saying, oh, it's white matter. But I think over time, the distinction between white matter and gray matter
Mm-hmm.
and the importance of worrying about them has changed. Can you just address that?
Yes, we were always historically worried about what's called the gray matter, and that's a thin mantle of the cells that are directly on the surface of the brain. And the white matter is basically that cell is sending a signal to the rest of your body. And so you can think of white matter as the highway. We were always more focused on the actual cell which produces the signal. Say, well, the highway's fine, don't worry about it. It's kind of amorphous, and we're not really sure where those tracks go anyway. But you know, there's always, everyone says, you see in the movies, we know what 20 or 30% of the brain does. That doesn't mean 70% is useless. That just means we don't know. And I think, in my opinion, 100% is useful. And just because our knowledge is not to that level to fully understand what, you know, what potential implications it has, I think a lot of that has to do with just, you know, as our understanding has grown and about the importance of all the areas of the brain, I think that definitely probably had a lot to do with why you're getting, you know, as our knowledge improves, our recommendations improve. So what we thought maybe 20 years ago was less important, now we're saying, oh, wait, you know what, we're wrong. Those are important too, so.
Nikki and then Lawrence, and of course, Dr. Waddle, Dr. Zafar will come next.
So back to the vitamin D thing.
Mhm.
So I had a blood test, and my vitamin D levels actually came back as in the normal range. I guess
Mhm.
normal range is like 25 to like 50 or something. And I was at like 33, so a little bit on the like lower side, so considered normal, because I talked to my pharmacist and seemed to be normal, don't really need supplementation. But then in talking to my neurologist doctor, said for cavernoma patients, it's probably recommended to go ahead and do supplementation to try to boost that. Can you comment on that?
You know, for as far as recommendations, well, the good thing with vitamin D is there's almost no downside to it. And so we can be much more liberal with prescribing things. And like, just like with surgery, whenever we recommend a medicine, it's all of what we're looking at, what is the harm that this medicine could do versus what is the benefit that we get out of it. You know, for vitamin D, the harm is exceedingly low, zero in essence. So we can be much more liberal prescribing it, and even prescribing it to officially normal, and find that you know, it is a, and since the cost of it is so cheap, it's not a financial burden for a lot of people. Then we can say yes, it won't hurt to do it.
Potentially help.
Yeah, it could potentially help, but again, we still need to learn more about it before we can say that conclusively.
Lawrence?
You talked about the need to address the hemosiderin
Mhm.
residual in surgery. For surgically refractory cases, is there a pharmacological approach that destabilizes and then toilets the iron residue because it's so toxic?
Well, unfortunately for that, that is in the gliotic part of the brain, the part that's scarred. You know, for helping with epilepsy in those instances, we generally rely on the anti-epileptic medications. You know, if you can't, for one reason or another, remove as much or all of that gliotic brain, the hemosiderin ring, because a lot of times it's not safe to do it. It's like, well, I can cure you of your seizure, but guess what? You might be paralyzed on the left side of your body. That's not a trade-off that's worth it, you know, when you're considering surgery. So then you do have to rely on the medications and things like that.
How about in the cord?
In the cord, the good thing is in the cord we don't have seizures. So seizures are generally from the supratentorial compartment. Basically, we have the posterior fossa and the brainstem. We're not as concerned about seizures. There, we're concerned about hemorrhage, just like the spinal cord. For seizures, we're worried about the cavernous malformations that are up at the top of your head. So that becomes, that's not really a consideration for us as far as removing all of that. And spinal cord is just like the brainstem. The more things you disrupt, the more problems you're going to have. So we want to just reduce, or eliminate the hemorrhage risk. So we're just worried about the cavernous malformation itself.
Not worried about the long-term neurotoxicity and inflammation.
No, again, it's that balance. You know, you're going to say, gosh, I can peel that off, but I'm going to disrupt some of those fibers and some of those pathways, and your legs might not work the same, and that's not worth it. Whereas it might be a chronic problem that develops over 10, 15, 20 years, but at least during that time, you've had a much better life than if I were to put you in a wheelchair, you know, tomorrow. So, all right, thank you very much. Thank you.